some time having completed his fellowship here before moving on to a faculty position. He has an illustrious funding career and prolific author and really engaged individual, particularly in the area of lung cancer and disparities. This is one of an opportunities that it's so rare when I have the opportunity to really introduce a luminary, someone who's been a role model and mentor and advocate in the community, particularly in the lung cancer space and disparities. He is someone that truly walks the walk in terms of having a perspective that engages the community, that addresses those key challenges that underlie our challenges in making sure that all of our community members have access to optimal care. And like I said, mostly in the lung cancer space. He has received wide recognition for his work and energy allocated in this space, including a Lifetime Achievement Award from the NCI for his work on health disparities. This is someone that truly invested his time in community engagement and the idea, although those of you familiar with the Cancer Center Support Grant know that community outreach and engagement is increasing in importance and is really a centerpiece of the NCI Cancer Center designation. That is something that's come naturally to Dr. Nguyen and is something that he has exemplified throughout his career. And so I'm not sure, Ellen, do we know if he's on yet so I can stop embarrassing him?
I haven't seen him yet.
Okay. He is not here yet. So we'll continue to work on to make sure we can connect with him, and I will go quiet for a little bit and kind of bump in once we're able to connect. So thanks for everyone's patience and apologies for this delay. Welcome, Dr. Nguyen. I appreciate your persistence in checking in with us, and we look forward to your comments. I went ahead, and this is Jamie, by the way.
Oh, Jamie, man, listen, I know you.
To save you some time for your presentation, I went ahead and introduced you and said a whole lot of horrible things about you, and so you can be properly embarrassed. And since we're recording, we can go back and show it to you at some other time. But without further ado, Dr. Nguyen, we're really excited and appreciate your time and persistence in joining us and sharing your thoughts about truly something as profoundly important as addressing cancer disparities in the 21st century. So thanks, Rob.
Well, no, thank you, guys. And I apologize for not being able to get on, but I was not going to miss this for the world. I mean, it's like coming back home. I miss Colorado. I miss you all, and good things are happening here. But I have to say that the place where it all started was in Colorado. And every single day, I am grateful that I had time to spend out there. And one of these days, I'm going to come back. That's not a threat. That's hopefully, that's an aspiration more than anything else. So this is a little bit of a talk. There was a famous musician, was called the Fifth Beatle, Billy Preston, who had a song called "Going Around in Circles." Will it go around in circles? And he started off by saying, I have a song that ain't got no melody, but I'm going to sing it for my friends. Well, this particular talk is going to be a talk that probably doesn't have a whole lot of data, but I do think that it's timely, and I want to share it with you. I'm going to actually really focus on a couple things, and that's trust, structure, health disparities during this pandemic. And again, this is just a financial. I will not be discussing anything or off-label use or investigational use of anything in my presentation. I want to start off by sort of saying when values are strong, rules are unnecessary, and when values are weak, rules tend to be insufficient. And as I think about the folks who've in part also helped frame what I do every day, even in the context of my being a cancer center. I'd like to just give some credit both to Elijah Cummings and John Lewis, both who succumbed to cancer, but both who were amazing fighters in the context of ensuring that our North Star in medicine was focused on making certain that we kept the reduction of health disparities in the center of that. Knew both of those guys, and they were really super instrumental in the time I spent in Chicago of helping me to shape what I'm doing now as a cancer center. I want to talk about other people, that Chadwick Boseman and Natalie DeSalle-Reid, who ultimately also recently succumbed to cancer, as many of you know. And again, when I'm within at-risk populations, particularly African-American populations, I use these two folk just to actually make the point that while we are very used to saying that cancer is certainly a disease of the old, that is not necessarily true. And in the African-American community, that certainly is not always true. I'm going to harken back to some of these slides and go through quickly. We're on the verge of we are on our 50th anniversary, celebrating the 50th anniversary fairly soon of the war on cancer and the establishment of the first NCI designated cancer center. What I really love about this picture is that not only is there not a diversity of race and ethnicity and class, there isn't even a diversity in the context of the sort of scientific focus. And so this is a program that many of you know came out of the work from Richard M. Nixon, but also Ted Kennedy, who's looking right over the right shoulder of President Nixon. Listen, the NCI designated programs has clearly brought a bunch, really amazing progress. Certainly science over the last couple of decades is really, and the marvels of science have really made super impact, whether we're talking about the genomic advances we've made or the technological advances we've made. It is absolutely true. And I was part of the first precision medicine initiative that looking at the use of precision medicine and artificial intelligence, machine learning to actually do good. All of these things clearly are advancements. We just recently published, if you haven't seen it, the first AACR Cancer Disparities Progress Report, which I think that if you haven't seen it, it's available and take a look at it. But what was really interesting about that is that this had not been done before. And so we took the opportunity as a group with John Carpenter and others to really kind of get our act together and put together some interesting data. It's interesting to know that it is not all grim in the cancer world, and the fact that we certainly with Black-white disparities have reduced Black-white disparities in cancer deaths overall. However, though, it still remains that there are significant disparities if you look particularly at certain cancers. For example, it's well known that African-American men and women still have 111% and 39% higher risks of dying from prostate and breast cancers compared to their white counterparts. It's known that American Indians and Alaska Native adults have twice as likely to develop liver and bile duct cancers. And it's interesting to know that Latino children and adolescents are 20% and 38% more likely to develop leukemia than their non-Hispanic white counterparts. As we think about this stuff, I really want to take a pause because we're not going to get away from COVID. And so I might as well just put my COVID cards out there right now and talk really about that, how COVID really has enabled us to see some things in a post-COVID world or in a going through a COVID world than we were in a pre-COVID world. I would sort of say to you that many of these same things existed in obviously these issues around racism and structure and trust and disparities clearly were there before COVID-19. But as many of us recognize as we've gone through the COVID-19 process, that things have changed. One of the things that I thought was a great positive that came out of the COVID, this COVID era is the fact that the NIH and the NCI, and then you have Ned Sharpless picture to your right, that all of us It wasn't just an infectious disease sort of a call for the infectious disease folks to just step up. It was a call to all of us. And many of us throughout our cancer centers have addressed this issue in the context of how do we actually impact our communities? Now, again, as we start thinking about differences, we know that Black male and Black females still to this day have a disparity within their cancer outcomes. And particularly this one is just pointing towards cancer death, where you're looking at the top line is African-American males, the bottom blue line is white males, and you have, again, this pink line illustrating itself as Black females versus white females. And the interesting thing is that it is true that in general, we are closing the gap. But what I want to tell you is that that gap is not closed. And in many cases, surprisingly, with some cancers, it's not only has it not closed, it's either stayed the same or in a few have gotten even worse. But the craziest part about this is that as in the backdrop of all the miracle cures that we've been coming up with, immunotherapy, the molecular targeted sort of approaches that we've gotten, all of the new technologies, the ability to be able to diagnose cancers quicker, faster, better, we still have a disparity. This was listed back in 2016, where we talked about the immunotherapy divide, and Dr. John Stewart and I have written about this now extensively in the context while we have clinical trials and we say we want more African Americans and diverse people on these clinical trials, they face hurdles on even getting into the clinical trials. The crazy part about this is that we've also learned that during this COVID period, that these issues of the disconnect between our health centers and our communities have always been there. COVID's clearly exacerbated that. This is an example of a pre-COVID sort of headline: Cleveland Clinic grows healthier while its neighbors stay sick. But many of you also know that during this COVID period that we have data that says that if you are nearby and happen to be close to an academic medical center or a high functioning medical center, it stands to reasons that your COVID outcome, whether you're Black or whether you're white, is better. Then if you're in a neighboring or a neighborhood in which the only access you have is to sometimes a safety net hospital. Now, on the one hand, we essentially says, well, duh, that's of course. But if you're looking at a structural and societal sort of behavior from a social justice sort of lens, or looking at science through a lens of social justice, that should bother us. The interesting thing is, as we have moved through COVID, clearly we have uncovered that that there are definitely communities of colors and other communities that were certainly disproportionately hit harder. Now, the one thing we've learned through COVID is that to not do the blame game anymore, and so to say, well, the African Americans, they have comorbid diseases, that's why they're not doing so well. Well, in part, that's not true. What's the situation that actually, or the structure that allowed for the comorbid diseases to exist in the first place? I really do think we're finally getting beyond scratching the surface and to really trying to understand that this is not a complex issue as much as it is that there are just multiple levels that need to be addressed. And Richmond was no different. The African-American population here in Richmond were dying twice as more likely to die if you're African-American than if you were white. It's been great to see the efforts by our scientific community. This is just Anthony Fauci talking about early on, back in June, if you guys remember that, about moving forward with warp speed. And then ultimately having our headlines that we've had recently at the end of December about that vaccine being made. The interesting thing is, this is where it matters, because we as scientists believe that once we've discovered things at the bench and once we get into clinical trials, well, then we can wash our hands and it's all over. It's interesting to know that even though we've accomplished something that is amazing, we've gotten 2 vaccines, mRNAs, through even different sort of approaches to create these vaccines, and yet we only have 9 million people to date that have taken the vaccine, where we should be around 20. It says that despite our best efforts, that we could certainly take the approach and take the attitude of, well, it's not up to us to do anything other than just to discover. But on a practical level, what COVID has taught me, at least in this context, is that there is certainly a disconnect sometimes between the discovery scientists and the implementation of that science into our communities. And that just because you make it doesn't mean that they will take it. And in fact, I think this COVID vaccine has been a good evidence of the fact that there's more than just creating these new miracle drugs. It's about building trust within our communities. Now, in the backdrop, we've had other things in addition to COVID that many of you know, from George Floyd to Breonna Taylor to what have you. Many of you, probably just like I did during that period of time post George Floyd, when we took a knee for 8 minutes and 46 seconds. And I did that with one of my deans, Dean Peter Buckley. And his comment to me after that is that it felt like a lifetime. And it certainly was. We're reminded during this period that all of us have a little Amy Cooper in us. And for most of you who don't know the story, this is where we talk about the unconscious bias or the use of our privilege when we're walking around just thinking that we're not making any difference to anybody, we're just being us. Most of you know the story of Amy Cooper, who called 911, called the police on Christian Cooper during this really turbulent time. Christian Cooper was an African-American, avid bird watcher and graduate from Harvard, who simply said to Amy that you have to put your dog, which was misbehaving at the time, on a leash. I say that because when we think of racism and systemic racism, I've been sort of now come around to the fact that it's not so much that structural racism and systematic racism and all these things that we talk about, they're not so much an individual flaw as they are a structural flaw. And I'll talk about that in a minute. I'd also like, before I start talking about this process of the structure, like to also point out that we've learned more than ever before that even in science, there are blind spots. It's almost like having being asymptomatic COVID carrier, in which you feel fine. You're like, I don't have any symptoms. I feel great. But what we've learned from the asymptomatic COVID carrier is that while you may feel great, you may be inadvertently affecting others around you negatively. And that is actually the awareness that I think we've all gained through this period of getting through COVID, particularly as health professionals and as scientists, is to understand and be aware of us not trying to be asymptomatic COVID carriers. So when we talk about things like structure, we have to recognize that when we talk about the comorbid diseases that exist in many of the populations that we study, there's nothing inherent about them as much as it is that they have been put in a structure. In some cases, redlining, which was a policy and a practice dating back to the early 1930s that was initially meant to get housing for people, wound up being something that was a very negative for many African Americans throughout this country, because at that point, there were populations of people who didn't want to live or have African Americans be able to even afford houses or live in their neighborhoods. That established things like, this is a picture of Chicago, and I only say that because we know that since the 30s, people have had disparities in Chicago, predominantly on the south and west sides of Chicago. If you sort of say, well, what, cardiovascular disease, where is it the worst? It's on the south and west sides of Chicago. The worst childbirths, where are they? But those things were set in play long before 2019, 2020. This is an example work done with Steve Wolf that just looked then in Chicago at a difference of roughly about 16 years. If you look to your right, there's something called the Loop. The life expectancy there is 85 years. And if you look to your left, there are two communities, but the one called West Garfield Park is 69. Now, the reality of that is that that's what roughly about literally about 4 or 5 train stops, which means it's probably less than roughly 5 miles away from the Loop. And there's a 16-year difference. The interesting thing about that is that we look at these things and we say, oh my God, what's happening here? Without really recognizing that the what's happening here is based on structures. This is just an example of what the American College of Radiologists wanted to establish what are called breast imaging centers of excellence. And what we can see, again, picture of Chicago that you have on this side, west and south sides of Chicago. The pink represents where you have the greatest amount of deaths. And the pink ribbons are supposed to represent where we have the breast imaging centers of excellence. And it's interesting that while those pink ribbons may be near some of those areas, it's interesting how none of those pink ribbons were actually in the areas that actually you had the highest mortality and the highest death. I say that to say that in 2019, in 2021, it makes no sense that we have headlines like this where you can say that in a Streeterville is in that sort of loop area that's only roughly about 8 miles away, maybe 8.5 miles away from Englewood. Englewood is an area in which Derrick Rose and people like Bernie Mac, a famous comedian, grew up, known on the south side of Chicago as being one of the poorest. But the fact that in the 21st century, we have a 30-year life expectancy is insane. Now, the truth of the matter is, I use this to think about lung cancer because when I first came to Virginia, most people told me, well, lung cancer is not that big of an issue. We're doing actually okay here. And it turns out that was only true if you lived in certain parts of Virginia. Where I am cancer center director right now, we have the worst outcomes for both lung cancer, the worst cancer burden overall in the state, and some of the highest incidence of many of these cancers. So it was welcomed that many of us shaken after George Floyd, after the Amy Cooper issues and many of the other issues, that even in science, we were able to turn a mirror on ourselves and think about the systemic racism that even existed in science. We frequently say, well, science can't be racist, we're objective. Not understanding, well, I would say there's a superficial understanding that all of our experiences really kind of that we bring to science is based outside of just the bench. What you're interested in, the language we use, the people that we actually even have at our benches and our networks are influenced by more than just being objective. And in fact, it was really nice to sort of see that there was a reflection or a moment of reflection about how in science we must also listen, learn, and certainly as we move forward, change. So trust became really an issue, much more so than it ever has before. And we all know about Tuskegee, but listen, this stuff has been going all the way back from the early days of slavery, where the father of modern day gynecological surgery experimented on African-American slaves at the time, because he thought that they were the best subjects to use because they didn't feel pain or experience pain in ways that his sister or his mother or his cousins would. And many other examples. And interesting enough, while most of us are comfortable talking about, Tuskegee because we say, well, that's 1972, the truth of the matter is, even in the 80s and even in the 90s, we can point to some of these disparities that would earn some of these communities from not trusting us. So when one says, well, we've created this wonderful vaccine for you, why won't you people in these at-risk populations take it? And not to actually for a moment pause and understand that there is legitimate reasons for many of these communities to be distrustful and to at least validate the ability of them to, at least at a moment, have some suspicion about us, is something that I think we all are going to need to think about. Now, listen, it was Richard Nixon once who famously said, even though I'm paranoid, doesn't mean that I don't have people after me. I would even say to you that these communities may be a little bit more aware and paranoid than other communities, but it doesn't mean that people haven't done, or people even to date don't have the best intentions in mind when they're interacting with some of our communities. So let's take a moment to understand that when we are so proud of ourselves in the academic communities about coming up with miracle cures, that we also have to do the other thing. And it's that disconnectedness of how do we go from discoveries to implementation, but how do we go from implementation to building trust? I'm going to submit to you that we will certainly come up with even more amazing drugs, amazing cures, amazing technologies. But my fear is that as we're coming up with that, we're impacting maybe the 1%, 2%, or 3%, but we're really not impacting those areas that could really use our science to help them. In fact, my whole career at this point has been about how do we bring science and how do we bring our communities closer to science. I just want to for a second tell you though, that while we feel that all this stuff is new, I want you to take a moment and just check this slide out, because this gives me a moment of pause. This is from a very famous progressive African-American named W.E.B. Du Bois, who wrote the first paper on disparities back in 1899, who described the two Americas, who described poor housing, unequal education, and many other aspects in 1899. The wonderful part about this is that we're thinking about, wow, we have a pandemic and we have this racial unrest. That's never happened before. Not true. Spanish flu pandemic in 1918 killed 675,000 people within the US. But during that Spanish flu and that respiratory pandemic, the way we're having now with COVID, we also had some of the worst race riots in the United States up until that time. Gun battles, fighting in the streets, things within Kansas and Chicago. It, in fact, was called the Red Summer. This isn't the first time in the United States that we had both a pandemic and racial unrest and that intersectionality. The question isn't so much that we haven't had this. The question is, what did we learn, if anything, from the last one? Now, I'm not one to say that we should be stuck in history, but I am one to sort of say that as a good scientist and as a good historian, that recognizing some of these things and learning the lessons from these things can help us propel forward. I always say this to tell you that I think that as we're talking about, and I may switch slide decks for a second, one quick moment, because I want to really say to you as we're thinking about this, that I think we now have more than ever before an opportunity, literally, an opportunity to make some differences this time. And one of the things, right before I show this, because I literally just have to show this slide to you because this is just amazing to me anyways. I think it's here. Let me see if this new slide comes up. Sorry about this, but I just have to show you this. If we go back to the 1960s and you go back to the Watt riots back in Los Angeles in 1965, when they tried to understand what the root causes were for the riots and the unrest, they came up with unemployment, disproportionate in these African-American communities, poorer schools, inferior living conditions, residential segregations, police discrimination. What do I show by this slide? What I'm trying to get at by this slide is that simply that this issue of health disparities isn't new to us. Interestingly enough, the solutions for the reduction of these disparities is also not new. In fact, there have been many blue ribbon panels dating all the way back to the 60s that have been very, articulately done by blue ribbon panels that we absolutely know how to reduce the health disparities. It's a little bit like I told someone a diet or being overweight. We all know that certainly being at a healthy weight is a good thing. We also know that there are hundreds of diets. All we have to do is simply pick one of those diets. And if you simply committed to that diet, in general, most of us would lose weight. Health disparities is not so much an issue that we don't know, we need to study it more. Well, certainly, I think in some of the nuances and being able to understand it better is a good thing. But let's not pretend that we don't have data dating all the way back to 1899 about disparities. Nor let us fool ourselves that we don't actually have solutions for these things. What we have lacked is the will to implement in a sustainable effort things that we have already known so that we could put them into place. So listen, COVID-19 did something that was really helpful for me about reminding me about the importance of community and reminding me about trust. So we've had a really, what I would say, probably one of the most influential faith-based leaders in all of this region, and particularly in Virginia, named Bishop Gerald Glenn. Some of you may remember that name because he was famous for saying, God is larger than COVID-19. And in fact, many of you may know that you know him because he was in CNN, Washington Post, New York Times, et cetera, for having died from COVID-19, as well as a couple of people in his church and a family member or so. That sent a shockwave through much of the African-American community and certainly the faith-based communities. And imagine going back, if you can go back to the spring, remember back in March and in April, our libraries were closed, our schools were closed. And as Martin Luther King, as we approach Martin Luther King Day, when he talked about the pillars of our community, you had the clergy, the fraternity, sororities, the press, the professional organization, many of those things were out and they were closed. It dawned on me, how was I going to rebuild trust in the community, but how was I even going to get to the community to be able to talk about testing with COVID, or even for that matter, lung cancer screening? It turned out at that very moment that one of the few anchor institutions that was left was the faith-based community. We subsequently turned an effort with Pastor Gray and Rudine Mercer Haynes, and we got together and we started talking about an effort that we would put together where your COVID was not so much a test of your faith, and facts and faith didn't have to compete. They weren't at war at one another. It turns out that we had to reawaken many of these faith-based organizations to not just be ecumenical in their approaches, but these were the same institutions that I quickly recognized during the COVID period were giving food to people throughout this period. That were, when people had to go to work, coming up with ways to watch their kids. Figuring out ways of, for example, how to use churches safely so that with distancing and all the rest of that, that there was at least some internet. Remember, we keep talking about all this high tech and high technology, but all broadband is not equal. And even in many of the urban areas, there are places where people didn't actually have legitimate sort of internet. And these folks wound up filling that gap. Well, it was at that moment that we decided that what if we were to actually have a real community effort of bringing the university, bringing internal, external knowledge, expertise about COVID with our large network of faith-based organizations. We call those Facts and Faith Friday. We recently had Dr. Fauci on to sort of talk about his perspective to these folks. There was an audience, roughly over 12,000 folk. We've been meeting, meaning we, the Cancer Center and myself, have been on phone calls with them ever since March, every week, without fail. People say, well, why would you do that? Well, it turns out that there is a lack of trust in these communities that if they don't see you, or if you only drop in for a month and you have an event and you don't show up for 6 months, there is, interesting enough now, I am more than convinced that if you want to gain trust, we have to be there, not sometimes, but on a consistent presence which we're visible. And bringing things to the community that are valuable for them. In fact, we joke that we are now, semi-joking, in a period where we're having to develop the Green Book for many of these communities on health and why. Now, many of you who are not familiar with the Green Book and hadn't seen the movie, this was things that my grandfather, my grandmothers, and other people in my family back in the day had to use to figure out which gasoline stations could you go to safely, what hotels could you stay in safely. Well, interestingly enough, I think we are in a period of time where many of our communities, with the misinformation, the disinformation, and the mistrust, are looking for how we can develop ideas and structures that they believe are safe and that there's good information is being coming out of. So again, we're ending up talking about this issue about the disconnect, as Harold P. Freeman have described, between discovery and implementation. But I would put another disconnect between the implementation in our communities. Now, how does this all add up to me? Community matters. I think we've been very good about figuring out the genomics of things. We've been certainly good about the phenomics, but there's another omic that's actually missing. And I would challenge you all to think about the fact of that my Cancer Center, I've now built and challenged them in the issue of understanding community omics. And that's a phrase we've gotten from one of my young faculty named Dr. Tosis. My goal of a community to bench model is, how do I get the omics from the community that I can actually take back to my basic scientists to help them refine their scientific questions, that I can take to some of my population scientists and help them not only refine, but help them define some of the questions that we should be asking, so that ultimately these questions and these activities go back into helping the community. I'll give you one quick example of how data matters. We started thinking about big data, and believe me, I'm a fan of big data. The bigger the data, the more secure the data is, the happier we are. But the one thing I was recognizing is that, at least in Chicago, same thing in Virginia, and I'm sure in other areas, that we didn't actually have data that really mattered to our communities. Frequently, it's as if I had a CAT scan and I took your CAT scan, and I would say to you, and bring in back when I see you as a lung guy, and I would say, yeah, you got a spot on the bottom of your right lung. This is not really your CAT scan. It looks like your CAT scan. It's similar to it. This spot, it's not exactly in the same place, but it's nearby. But hey, listen, in general, this is what we're worried about. Imagine that versus having a CAT scan where I say, Mr. Jones, this is your CAT scan. That spot at the bottom of your right lung, right there, is your spot. And here's what we're going to do to deal with that. We have no way of presenting currently data to our communities in which it would have that sticky factor to it. In fact, we talk in zip codes, which is funny because zip codes for most people are important for mailmen. But as one of the women in Chicago would once tell me, she goes, honey, I don't know no zip code. That's for the mail people. I know where I live. I live in the 20th ward. We don't talk to people in a language that they understand, and yet we get frustrated when we say to them, we've created this wonderful vaccine, or we've created this wonderful drug for you, and why won't you take it? Part of science, and this is why I actually am doing this talk today, is that there's an awakening that part of science now is, in addition to coming up with the miracle drugs, coming up with just producing science for science sake, but for those who are really talking about the application of this, we are going to have to pay attention to our communities more. And in our quest for bigger and bigger data, that we don't inadvertently, with the big data, make our communities invisible. This was my attempt, and I showed you the paper that we just mentioned earlier, that slide before, of an attempt to make communities visible and what can be done with the data. In Chicago, there were 50 different wards. Each ward is composed of about 50 to 75,000 people. We were able to say, pick out the physical ward, which changes every 10 years, but we were able to pick out the political wards. The political wards, again, we in Chicago anyways, we'd say, politics is to Illinois as football is to Texas, or skiing is to Colorado. And in this case, we were able to do the regular stuff, cancer incidence, mortality. We were able to talk about the uninsured rate. But the thing that made the difference was to put language in a way they understood it. And this is the next slide. This slide shows the cancer incidence and mortality rates in the 20th ward. And what made a difference with this slide when I sat with the alderman was that for the first time, he and the community hospitals and the neighboring community groups and the community health centers, like the federally qualified health centers, could easily understand that if I were to point to prostate cancer and sort of look at West Englewood as part of their group, or Greater Grand Crossing, which is part of their ward, that they had, in some cases, 3 times more deaths from prostate cancer than they did in the rest of the state or in the country. These data disseminated in a way, just like a CAT scan, that had a sticky factor for the folks in the community, allowed them to have a much more mobile sense and motivated sense of being involved in figuring out how to solve the problem. And in fact, as a sequelae of this, I just wanted to say, before I left Chicago, we did a grand experiment where we were able to show, at least at the University of Illinois Cancer Center, where I was cancer center director there, that we were able to outperform the National Lung Cancer Screening Trial in detecting cancer, particularly among minorities. Why do I say this? I say this because I am convinced that we are at a moment in history where we are being called upon as scientists to figure out how to bring our communities closer to our science so that we can benefit them, and how to communicate in a different way with our communities to not just get their buy-in, but to get them motivated to work with us in solving their problems. Now, I know that's a mouthful, and I tried to get through some of these slides, and I did skip over some, but I did want to say to you that I am super excited about coming out of COVID. Yeah, we're going to have some problems. There's certainly going to be many, many more issues around cancer. I went over some of the slides, or skipped some of the slides about the social determinants of health, because we all know that. In fact, I do want to remind people that the social determinants of health, which there's focus on it, but remember, those social determinants are not the beginning. They are the intermediate of your politics, your economics, and your policies that are impacting these communities. Now, there is an interesting paper that has just come out, I believe, not that long ago, that says we can predict a 3-fold more increase in some cancers in communities that have been stable for 20 to 30 years that have lived in poverty. It's not that hard. We're at a point where I believe that the ZNA, the zip code and neighborhood association, means as much as your DNA. And by bridging the focus of zip code and neighborhood association and those types of data, and bridging that to looking at our basic and DNA data, we're going to be able to make more improvements in our community. So I know that I'm running out of time, because I was late, but I wanted to just share this with you, at least this mindset, and just say, I'm sorry if I didn't show enough data. And I'm absolutely sorry if this felt like this was some Sunday sort of, you were hearing from some sort of Baptist minute. I can't help it. I think that we are at a moment in time where science can actually do good, not just for some people, but for a number of people. But we have to throw back in that context our role as scientists through a lens of social justice. And so with that, I'll end and say thank you for letting me revisit with you. I wish I was out there physically because I love Colorado. So thank you so much.
Dr. Nguyen, that is incredible. One of the things I mentioned about you is you walk the walk in terms of the community engagement. So you couldn't have highlighted it more in terms of, its essential role in understanding how we address some of these challenges. So your talk was wonderful, and we greatly appreciate the opportunity to hear from you. I have a ton of questions, but I want to turn it over to other folks. I don't know if Dr. Schulich, you have a question or a comment. Open it up.
Yeah, I just have a comment. And Rob, what a great talk from a great investigator. And I miss our days on study section together. And it is so fitting to hear this talk a couple of days before our holiday to celebrate a great American leader. And, again, the episodes and events of the last year have really uncovered a lot of the progress that we have not made in healthcare disparities and disparities in general. So I just want to be the first to thank you so much for doing this. And it was so on point and so summative of all the things that we have been thinking and need to think about. Thank you.
Oh, no, thank you. Good to see you again. I love you guys. I wish I could come through the screen and just hug you guys. I love you guys.
Are there any other questions or comments that folks have for Dr. Nguyen?
Yeah, Jamie, this is Dan Merrick. Can I ask Rob a few questions?
Certainly.
Hey, Rob, it was a really great talk. I really enjoyed that. It's great to see you again. I had really two kind of peripherally related questions. First of all, I was wondering, I think that there's been a real focus. I know my involvement with the Human Tumor Atlas Network of the NCI. We've been really focused on making sure we get a lot of diversity information and address some of the disparities there have been in research on cancer. And we've recently actually created a diversity working group. I think we've really zeroed in on a lot of informative data elements we want to get, but I think it's a little more difficult to make sure that in our cohorts we have a representation of the full population. And I wondered how you might suggest people try and approach that. And then I guess the second question is somewhat related in that I believe really ultimately for diversity to be fully engaged, that across all socioeconomic, across all different professions and stuff, really the people involved in all of those should represent our population. And it's my understanding that sometimes it is difficult in areas such as medicine and science for certain ethnic groups to progress to leadership positions. And do you think we have enough support to help people in that goal, in those goals?
And great to see you again. I'll sort of say to you that one of the things I had been thinking about is our approach to that. So I'm hoping, and I'm making the announcement, but you guys, because I'm hoping that you guys will apply. You may have heard something about the Bristol Myers Squibb Foundation grant. If you haven't, it's a $200 million grant. That was initially started as a pilot program at VCU. I was supposed to do it as a pilot program at VCU. And then subsequently, the crazy part about that, it then became I wanted to then have a network of cancer centers, and then it became just a national thing. So that program is the first of its kind to do what you're trying to say, Dan. Not only are we trying in that program to train the best and the brightest so that they actually become better clinical trialists. So they're going to have a network of the AACR and everybody teaching them how to be great clinical trialists. But a component of that, it's the first program in the country that's teaching them how to be connected to the community. It's my thought that it's just not enough to put minorities just in these places or put people who are health disparities focused in these places. We're missing a training. And part of the training is once you get that great, amazing clinical trialist, there's another skill set they need to learn, and that is how do they leverage, how do they find out the resources of a community when they actually go there? How do they network that community? How do they leverage that community? And how do they connect with the community? And that's not just something that happens. That is something that actually can be taught. And that's a skill set that to this day, we don't have a program that does that. So we're starting the first in the country to start that. And we're hoping that more programs over time will hopefully incorporate that aspect in it so that, you know, Jamie and others and myself and Kareem Watsons and the, Consuelo Wilkins can actually sort of say, not only can you be a great scientist and a great clinical researcher, but here's some skill sets of how you can put into practice connections with community, because I don't know that we're going to change this otherwise. And to your point, we definitely need more diversity within the workforce.
Jamie, can I ask a question? So, hey, Rob, this is James. Great seeing you again. I really miss the annual Peach Fest in addition to having you as a colleague. But I really thought that was a powerful talk because there was a real call to action. And I like what you said about, yes, we need to keep collecting data, but at the same time, we already know these we know enough about these disparities that we really need to get moving on addressing them. So, and this is probably an unfair question, given that you don't have another hour to speak about it, but what's the low-hanging fruit? I mean, if you were in charge of the national policy, what would you hit first? What would you say are the easy things to do that can make a big difference?
Yeah, and so the easier things that I think are we're going to have to move that way is that I do think that resources from the NIH are going to have to go, and it's not a redirect, so I'm saying add more resources to the pot to do much more focused around implementation science. I think we're going to have to. The second is I do think that, and I'm a basic guy. Listen, if love and basic is wrong, I don't want to be right. I still love at my bench, I'm playing with my RNA binding proteins, but it's come aware that disconnect between the discovery and implementation is real. And we are going to have to take some resources and the second is that we are going to have to train our workforce differently. One of the reasons why I wanted to UMassey, where we took in this case, clinical researchers, but we're hoping to do the same thing with some basic scientists. How do we get our basic scientists to be much more sensitive and aware of community data that can refine their scientific question? I think that there is an opportunity here, particularly in this awakened state that we are in and going through, as long as you get past January 20, no political comment, just get past January 20. That's all I'm saying. I didn't say anything else. Just get past January 20. But I think we have an opportunity to start thinking about how we train these things differently. And that is, we're connecting our basic scientists to the community. But I also think this omics of community, the community omics, which we're getting data from, if we brought that to a basic scientist and says, here's what the community's problems are and the issues are, and here's what they're hoping, how could you refine your scientific question to impact them? Those are the types of things that I think we're going to have that are the low-hanging fruit that we can move towards.
Yeah, great. Thank you.
Thanks, James. And you're right. I think we could, spend hours and hours talking with Dr. Nguyen to help us refine some of our perspectives and how we can apply it to our community. But Rob, I want to close out. Thank you so much for your time. It was well worth the additional couple-minute wait. We appreciate it. And for those of you who are lucky enough to be able to spend some more time with Dr. Nguyen this afternoon, maybe we'll give him a couple minutes to transition and start some of those meetings. So thanks everyone for being here, and we look forward to building on your comments today, Dr. Nguyen, and discussing them in more depth in the future as they relate to our cancer center and our community and those folks that we really do want to serve and make sure that they benefit from our innovations in the same way the majority community does. So thank you.
You know what? There's a C in VCU. There's a CU in VCU, so I'm not that far. I'm always I'm hoping to, to form some relationships, and some partnerships between our two institutions.
All right. Take care, everyone. Thank you for being here.
Thanks, Rob.
Thank you. Jamie, I didn't know whether I was supposed to leave this and get on another link.
Well, Ellen will tell us and let us know what how things are working.
I'd like
And
you
you
to
know
get
what?
off this link because we got to record this and we're going to post the recording.
Okay.
But there's
And
one
and
more
I
link.
apologize. When I got on, I was in a loop of just one, and then I tried it. Sorry about that.
Sorry if I did something wrong there, but there's one other link that I sent you for all of the meetings this afternoon. So everybody's going to pop in and out of that one room that you're going to stay in. So you won't have to pop off after we get into the next room.
Thank you. So I'll leave now and then get on the other link.
Yeah.
Thanks, Rob. I'll talk to you later this afternoon. Thanks, Ellen. See you.
Yep.